Hi, good morning, everybody, and welcome to Monday Morning Grand Rounds. I'm really delighted this morning to welcome back Dr. Maurice Sarano. We're always thrilled when he is our speaker. As many of you know, Dr. Sarano, for many, had a storied career at the Mayo Clinic, where his work is largely responsible for how we treat mitral valve regurgitation with early repair. And Dr. Sarano retired from that work and failed retirement shortly after he left, and we saw an opportunity and invited Paul Saraja invited Maurice to join the Valve Science Center several years ago now as a senior scientist, and he's been a remarkable addition to our scientific work and to interacting with our scholars, many of whom are here this morning. And I also would like to acknowledge that Maurice's work with underserved countries and young adults and children with valvular heart disease and another aspect of his career. I invited him this morning to talk to us on arrhythmogenic mitral valve prolapse because of his expertise, and it's a timely topic. Dr. Sarano, thank you.
Thanks, Scott. Scott is a way for me to feel good. Huh? I need to meet him much more frequently and have a good time here. So today, let's go to the medical science thing. Today is the arrhythmic mitral valve prolapse, and the question is, why do we talk about this? Because sudden death, evidently, is a no return event where it's the flicker of God sort of eliminating dust from its lapel, and we are the dust. And so we don't want that to happen. We don't want to be there. So we're going to talk a little bit about a case and about what happened to this patient, and also about the sort of division between patients with degenerative mitral regurgitation and patients without degenerative MR. And so this is the case of a 72-year-old who was my patient, asymptomatic with DMR, and here we quantify DMR as you expect me to do, and he had the sort of moderately severe MR with he was somewhat hypertensive, so the regurgitant orifice was 0.3 centimeters square, and the regurgitant volume was 84 cc's. But he had zero interest in having surgery, despite my great conviction towards that. And I said, okay, let's do an exercise test. And he did 12 minutes on the O2 protocol, double product 31,000, 26 milliliter per kilo per minute, or for his age, 107%. So he was doing better than the average for his age. But at the peak of exercise, that's what we recorded, a brief ventricular tachycardia, episode of ventricular tachycardia, but he was still uninterested in doing surgery at the time. And 1 month after his last visit, he was still working at 72 in Rochester. So everything was kind of simple to get to him. He was sitting on a box, and then he fell on the floor, unresponsive. 911 was called, and because it's Rochester, it was kind of quick to get there. So they were there, and the patient was shocked twice, and he returned to sinus rhythm from ventricular fibrillation. And in the hospital, he was neurologically intact. ECG was in sinus rhythm. Physical examination, nothing, no sign of heart failure. CT was okay for the brain, and we did a coronary angiogram and LV-gram, and the coronary angiogram showed LV-gram. You see, it's a LAO, and there is dye here, and then the coronaries were showing minor lesion. 40 and 50%, so nothing dramatic. And then after we did the LV-gram, so EF was calculated 59%, and the MR was called moderate, but we know that angiography is not very good. Oopsie, sorry. Well, so go back. And so after that, we decided to do surgery. the patient had the mitral valve repair. He had also 2 bypasses for those minor lesions. Who knows what it does? And he had, after that, an ICD implanted. And he never, during the following years that I followed him, he never discharged the ICD once. So this is the sudden death in patients with degenerative MR. And there was not much, and there hasn't been much literature. Here is our paper from 1999. My friend Francesco Grigioni, who is now professor in Rome, was fellow at Mayo at the time. And we had 348 patients with flay leaflet, and they were, as usual, mostly male, relatively rare atrial fibrillation, hypertension, and mostly posterior leaflet flay. And you see that sudden death in yellow here represents 1 in 5 of the cardiac mortality. At the time, we could determine the cardiac mortality, not many cases. The cause was easily determined. And if you calculate the rate of sudden death in those patients, it's 1.8% per year, which is very high, very high. However, you have to look into the different subsets. And as you can see, with increasing symptoms at presentation, the rate of sudden death increased markedly, was very high with class 3-4 and low with class 1. But if you look at the number of events, the majority of the events occurred in patients who were in class 1 or 2. Higher rate. Same thing with the EF. So EF was lower than 50%, very high rate of cardiac arrest, but the majority of events occurred in people who didn't have low EF by any criteria. And the same thing for atrial fibrillation. More sudden death in patients who had atrial fibrillation, but majority of events were occurring in people who had normal sinus rhythm. So so if we take out those 3 risk factors, the rate is 0.8% per year. And there is a background rate of sudden death in any population. And for that age, it's approximately 0.4% per year in the population, although the numbers that we have are not very good. So we have approximately twice the risk of sudden death in patients with severe MR in general due to flay leaflet than in the general population. It's twice the risk. And when you do surgery, you reduce the risk by 2/3. So you bring people back to the rate of the general population. And in fact, to address this problem, we have to remember that sudden death is a notable proportion, as we've seen, more frequent with symptoms, low EF and atrial fibrillation, but it may occur relatively often without risk factors, and it's markedly reduced by mitral surgery. We have to remember that if we look at the outcome of mitral surgery, I apologize for the dislocation of the survival curves, that if you operate on patients who have symptoms, you have residual excess mortality. The yellow curve is below the red line, so we have residual excess mortality if we operate with class 3-4. But if we operate with no or minimal symptom, we restore life expectancy so that the total mortality is the same as in the general population. So we probably restore, in operating on patients without symptoms, the rate of sudden death to what it is in the general population, because we restore life expectancy in general. And so operating on patients with the no or minimal symptoms is the best way to eliminate the risk of sudden death. And repair, here is an example of flay posterior leaflet. It's a very simple procedure where you remove the flayed segment and you put a ring, and it's a half-hour operation on these patients. And repair has a better outcome than replacement in red, repair in blue, and similar to the expected survival overall. And over time, we have seen the percentage of repair markedly increase in the practice and associated with a marked decrease in operative mortality on the right side of the curve, particularly in the older patients. So things have evolved in a way that facilitates the performance of repair early in patients with degenerative MR. And this paper that we published with my friend Rakesh Suri from the MIDA registry showing that early surgery has a better survival after diagnosis than medical management of this patient, the watchful waiting, even when we do a propensity study. So we have better survival, less heart failure, but similar rates of atrial fibrillation in this patient. But the best way to treat those patients is to operate early and to prevent sudden death. Now, what we have to remember is that it's not the license to do anything that you want, because if you leave a little bit of MR, you're going to have, with a red curve here, maybe I can show it. This red curve shows that if you leave a little bit of MR in the OR, you're going to have more reoperation in these patients. And if you have recurrent MR, you're going to have more mortality in those patients long term. So there is a need when you do repair that the intervention be perfect. It has to be, we have to aim to perfection, because otherwise we leave the excess mortality with a patient. So sudden death in patients with DMR, the best way to prevent it is elective mitral valve repair when they're asymptomatic or minimally symptomatic, performed at very low risk. And now the risk of repair is what, 0.4%, 0.5%. So it's really a very low risk, but with the requirement for the surgeon to have a perfect result to really suppress sudden death. Now we're going to a more disputable area, which is the area of mitral valve prolapse in general. The prolapse is a big extent from a minimal prolapse to a flayed leaflet. And so what do we do, and what is the risk of sudden death and arrhythmia in those patients? You know, the early papers, so this was one of the first paper by Barlow talking about outcome and saying this is a very benign, and this is systolic click, huh? Nice phonographic recording. That was how it was done, huh? So that's that was how Barlow came to be known, huh? And so he had very good outcome in those patients, very few complications. At the same time, people were talking about sudden death in those patients. And it's difficult to associate when you do case reports. So sudden death here, what does that mean? How do we interpret that? And there has been that discussion, and we're confused by discordant data on MVP outcome. So the big discordance is that we didn't know what we were doing with diagnosis in the past. We were diagnosing prolapse with a 4-chamber view where we saw the leaflets going back. And I remember working in private practice and doing echoes to people who are less severe than in the hospital. And every second patient, I was diagnosing a mitral valve prolapse, and I was saying, this is impossible. What am I doing? What is it that we're talking? And then Bob Levine did his first remarkable work on the you see the arrow? Yeah, on the shape of the mitral annulus, which is a saddle shape. And it took me a long time to understand what that meant. The saddle shape here is the saddle. So you're sitting on the saddle, holding the aorta, and having your legs on each side, and it goes down on each side. So you're sitting, that's the saddle shape in the long axis of the mitral valve, with the annulus going down on each side like a saddle. And because of that, the diagnosis changed, and the requirement was to make the diagnosis in long axis. And so it changed everything, because in the past, we had papers saying up to 17% prevalence of mitral valve prolapse. And then with the new criteria, they are not new now, but with the new criteria, it was really much more reasonable, between 0.6 in younger patients and 2.4 in mostly older patients of the population, which is quite a bit of people still in the US. And so if you look at the papers that were published in the old days on sudden death, we don't know. Maybe here, because there is a click, we may think that this is a real prolapse, but we don't know what's the value. And this is the paper published when he was a fellow by my former colleague Rick Nishimura, saying, oh, there are sudden death in mitral valve prolapse, but I don't know if these people have mitral valve prolapse in the first place, because this was published before the criteria change, and we had a definite diagnosis of mitral valve prolapse. So yes, now everything that was published before 1989 has to be disregarded. And so from now on, so what did we have after that? We had after that the paper in the New England Journal of Medicine. They were lucky birds. 84 mitral valve prolapse in Framingham. That's what they had. 84 mitral valve prolapse, and they said no complication. Now, I want to be honest with you. If you look at the methods in this paper, they looked backward. They said, okay, we have the last echo. They look, and did we have complication in the past? It's difficult to detect mortality when everybody is alive to do an echo. So nevertheless, it was published in New England Journal of Medicine. So when I saw this paper, I said, you can't let that stand. It means zip. So we need to have something. And it was published in the New York Times. You remember that time. So we talk about division, political division. And this is political division. This was the independent council and all that. So talk about political division was not different from what it is now. But there was mitral valve prolapse, not so serious, a little article here in New York Times. And so is really the mitral valve prolapse benign and uniformly benign, as they were stating in the paper. So we worked with my friend Jean-François Verinos. All my former fellows are now professor of medicine, which is very depressing. And so he's a professor of medicine in Marseille, France. And so we worked when he was fellow with me, and so we looked at the outcome of asymptomatic mitral valve prolapse, and what we saw is that here is the morbidity, mortality, and cardiovascular mortality in those patients who were diagnosed at 50 in general. And these are the factors of mortality, ejection fraction, and MR, and the other factors of morbidity associated with morbidity. And if you look at the distribution, most have no factors, and there is a smaller group with risk factors. Essentially, MR was the main risk factor. And if you look at the survival curve, there is very little mortality in patients who have no risk factor, and excess mortality in people with MR moderate and some with EF that is lower. And so this is the power of community work. And community is a closed community where we get all the cases, all the follow-up, all the procedures done, because, well, in my previous life, we were in Olmsted County, and Olmsted County is isolated, self-contained, and has all the care within that community. So we can say every intervention done, every event occurring, every diagnosis made in the population. So it's a very powerful epidemiological tool that we applied in valvular heart disease too. And you see cardiac survival, not a single death here. We had over 10 years. So how can it be that these people are dying like flies from sudden death? So I couldn't think about sudden death. And we did recently publish that paper on the large series, more than 4,000 patients with mitral valve prolapse, with quantified MR. And when you have the MR between none to up to 0.2 of regurgitant orifice, the survival is equivalent to the general population. So there cannot be a high rate of sudden death in those patients. Some people are trying to make a big deal out of sudden death, but there cannot be a big rate. But still, sudden death is a pretty significant thing. So what do we have to say? all studies are concurrent that MR severity is a major determinant of MVP outcome, poor outcome with severe MR, and benign outcome in the group with no mild MR. But this is a group. So we have other facts. This is an article that was published in 2002 by Proctor Harvey, who was a monument of cardiology. And he was talking about his son who had a mitral valve prolapse and who died suddenly. So there is nobody better placed to say this happens in those patients. And I have to say that the merit of pushing that discussion comes to my former colleague, Michael Ackerman, who had this weird series. I don't think I would ever have published that series of 24 cases of sudden death, sudden cardiac arrest, unexplained by long QT syndrome, and a group of 10 had bileaflet mitral valve prolapse, and he found the shocking title of malignant bileaflet mitral valve prolapse to express those people, that these people had the cardiac arrest due to mitral valve prolapse. But in fact, we don't know if they die with mitral valve prolapse or they die because of mitral valve prolapse. Because mitral valve prolapse is frequent. There are some events of sudden death. So can you say that it's the mitral valve prolapse that killed them? After sudden death, how can you retrace what happened before to make the link between the mitral valve prolapse and the sudden death? It's almost impossible. So when you have a group of people, how do you recognize that one case that is a serious case? And so what we were trying to say, okay, you can do a long work of clinical outcome, take 10,000 mitral valve prolapse, follow them for an average of 10 years, and then see who dies suddenly. But this would take 100 years to do, to gather the cohort, to follow them, to see who dies suddenly, because the rate of sudden death is certainly very low. So what we have to do is to try to see if these people have a specific, that we can detect a signal that this is really serious. So the first signal in that was by Cristina Basso, who is a friend in Italy, and she is a pathologist, and they have a series of sudden cardiac death in young people, and she had 6.6% of sudden cardiac death unexplained in young people that were with mitral valve prolapse. So we don't know how it happened, but that's the main thing. And she found a lot of fibrosis in those patients. So then they did a second study led by Martina Perazzolo-Mara on arrhythmic mitral valve prolapse that they don't define very well. And they did MRI, and they had a majority of patients with fibrosis detected, positive lead gadolinium. And these people had more often mitral annular disjunction, bileaflet prolapse, and complex ventricular arrhythmia. So they were putting a signal. But the paper that we did, and that was completely underestimated by circulation because they gave us a letter. You can publish a letter. The associate editor was sleeping at the wheel. We had a beautiful comparison between people with mitral valve prolapse that had died sudden cardiac arrest, and people who never had cardiac arrest. So we could differentiate and detect the phenotype if there was a unified phenotype of people who died suddenly versus those who didn't die. They had us taken out the normal. They didn't understand. We didn't make them understand. That's our responsibility. And we had like tons of data on 42 cases of sudden death. We had 23, and I think that there was 21 from several centers in France with mitral valve prolapse. And you see, I don't want you to read all that because I'm going to give you a little summary. We found that the people with isolated mitral valve prolapse, no other cause of sudden death and occurrence of sudden death, had a sort of triad of clinically syncope or presyncope before the event. Echo with severe myxomatous disease and annular disjunction, and ECG with PVCs from the mitral annulus or VT from the mitral annulus. So we had that triad of those symptoms. That is the main sort of underscoring of the severity of syncope or presyncope. Mitral valve prolapse, syncope, presyncope, you have to sort of worry that this is an arrhythmic mitral valve prolapse. So so this is the case that we presented in our review of mitral valve prolapse that we published this year in the European Heart Journal. This is a case of a 26-year-old who had a history of presyncope from 17. She had presyncopal episode, and finally worked as a nursing aide in the hospital. So she was lucky because she died suddenly inside the hospital, was resuscitated after 8 defibrillation, and returned to sinus rhythm. And this is the echo after. So there is a mitral valve prolapse. Sorry for the view showing that, but I made this to show that the LV and RV function was normal. And you see that there is a mitral valve prolapse, not that much, a little bit, just satisfying the criteria beyond the line of the annulus. And there is a beautiful mitral annular disjunction that we see here in this patient. And she had repeated episodes of ventricular tachycardia initiated by one extrasystole, and then she needed to have ablation. When we presented this case, the reviewer said, oh, but you know, how do you know that it's linked to mitral valve prolapse? And I don't know that it's linked to mitral valve prolapse. I'm showing the difficulty that there is in linking the mitral valve prolapse to the arrhythmia. We have everything, normal coronaries, no QT, nothing else. But how do you link? It's very difficult to link the arrhythmia. But the fact that there is a phenotype of arrhythmic mitral valve prolapse is very important. So in a recent review, Cristina Basso said that MAD was the red alert. I don't read the whole sentence, but big deal that it's the angel of death coming above your bed to kill you silently. So what is the mitral annulus? So we are going to talk briefly about the mitral annulus. This is the mitral annulus. It's a fibrous part around the valve. And you see that it's in between 3 things: the leaflet, the ventricular myocardium on this side, and the atrial myocardium. And you see that it has 2 functions. One, electrical function, because the atrial myocardium, if I can show it, the atrial myocardium in pink is separated by the annulus from the ventricular myocardium. This is why we conduct only through the AV node. So we don't have like 200 beats per minute because it comes from everywhere. So first, electrical isolation. Second, it's the anchor in the ventricular myocardium of the posterior leaflet and the atrial myocardium. And you see it, the septal, which is much bigger, the septal one, and the trigones on the top. It's part of the fibrous core of the heart. So very strong in the medial part, relatively weaker on the free wall part. And you see here the same structure, the atrial myocardium separated from the ventricular myocardium by the annulus that holds in the ventricular myocardium, holds the atrial myocardium and the endocardium of the leaflet. So it is that structure, and this is a normal annulus, and you see how it's anchored. It's like a tree with roots in the myocardium, and it holds that way in the ventricular myocardium, and that's the normal from this paper from Hutchins that was for long the only paper on mitral annular disjunction. Why they published that in the New England Journal of Medicine, I have no idea. But it's a great paper. And you see here the role of the annulus. You see how the ventricle pulls on the annulus, changes the shape of the left atrium. So the left atrium becomes from elongated ellipsoid to spherical. A sphere contains much more volume than an elongated ellipsoid. So the pressure in the left atrium decreases, and that's the X descent. The X descent in the left atrium is due to the action of the mitral annulus when it is pulled by the ventricle laterally to expand the atrium and decrease the pressure. This is why when we run, we're not short of breath, because we maintain a low pressure in the left atrium. We suck the blood out of the pulmonary vein. And it happens less when you have a very big atrium than in somebody with a tiny left atrium. But that's the effect on the function of the annulus. And the atrium has been the annulus has been always very difficult because you do a 2D echo, you see 2 points. How can you infer the function? But fortunately, there was 3D echo. That's an old 3D echo. It's terrible. But you can see very well that you have the whole mitral annulus that you can measure, that you can do physiology. And we did a little bit of that. And we did an animation on what is the normal function. Is like I'm selling something. And so we so the mitral annulus, you see at normal speed, it's very difficult to look at but if you go slow, you see that in early systole, it contracts. It comes in. The AP diameter decreases. And if we go on the side, you see the other movement in early systole. It is the accentuation of the saddle shape of the annulus. Those two movements are the only movements occurring on the annulus early in systole, and they tend to, while the ventricle is beginning to contract, to close the mitral valve almost passively, so that we should all have early systolic MR, because the leaflets are open, the ventricle begins to contract. We should all have early systolic MR. We don't have it because of those movements of the annulus. The AP contraction, the accentuation of the saddle shape in early systole. After that, it doesn't matter what happens because the mitral valve is locked and nothing happens. So that's that is. And that's the normal function of the annulus. And that's the pictures in Hutchins of annular disjunction. You see the 2 points showing that the annulus is here and is not implanted on the ventricular myocardium, another one here. So that's the first things. And I was in disbelief because I couldn't see it. And this is the same view, much better view, from the paper of Perzola-Mara on mitral annular disjunction, normal annulus, mitral annulus disjunction. And I'm completely ashamed that I reviewed this paper when it was submitted, and I said, what is this thing of somebody cutting the base of the posterior leaflet? Does not exist. I, Maurice Sarano, don't know about annular disjunction, so therefore it does not exist. Okay, I'm sorry. I apologize retrospectively to Erickson and to the people who sent this paper. It was a beautiful paper that I completely underestimated, but finally was published because they did the repair by sort of deinserting the posterior leaflet, and they saw a lot of mitral annular disjunction by the eye of the surgeon. And that's the only proof by the eye of a surgeon of a macroscopic annular disjunction. And you know that there is a lot of discussion about microscopic annular disjunction, like it's in everybody. What does that mean? Discontinuous mitral annulus doesn't mean a thing. It means only if it's macroscopic and affecting the function. And so if I play you this way, it's very difficult to see. I can underscore the detachment of the annulus from the muscle, but you have to do an analysis frame by frame, and this is why it took me so long to know how to see it. And in the first image, it is early systole. The annulus is still on top of the muscle here. The mitral valve is closed. Then a little bit later in systole, you see the annulus detached, and at end systole, you see the full detachment, and here is the muscle completely detached from the annulus here. And that's the depth of the mitral annular disjunction. Very difficult to measure because there are always tracts of muscle going to the annulus, so it's very difficult. Here, you see it better because we had a slower speed. You see the annulus at the base, a little denser, at the base of the posterior leaflet, sliding from the muscle and going backward, pushed by the ventricle. So it is frame by frame analysis is the way to detect annular disjunction. And there was a theory in Padua that mitral valve prolapse was preceded by annular disjunction, which I disagree completely, because you can see that we have 4 mitral valve prolapse, and the one on top left has no annular disjunction. There is prolapse, but there is no annular disjunction. The second one has a mild annular disjunction, moderate, and then severe annular disjunction. So there is a variation of the phenotype in mitral annular disjunction that is sort of part of the variation, and we see more myxomatous tissue in people who have a severe annular disjunction. So MAD, we need high resolution and analysis frame by frame to be able to say this is truly a MAD, and we have to see the position of the annulus frame by frame and measure the depth of the separation from the muscle. You can do it by MRI. MRI does it generally very well. That's a published image. But you have to be very careful, because when you look at it, it seems like there is mitral annular disjunction, but when you do frame by frame, you see that the annulus is still attached to the muscle, and that there is no annular disjunction here from diastole to systole. So imaging is critical here. That's the way to diagnose, and it has to have sufficient spatial and temporal resolution to quantify the MAD and to be sure that there is MAD in the presence of MVP. So what are the consequences, physiologic consequences of MAD? Well, we analyzed that by 3D echo, repeated measures that we did with a 3D echo of the annulus size and everything. And here is a case on top with MAD, and you see the myocardial consequences. So you see the separation occurring here, and maximum in late systole, and you see the muscle bulging. You see the muscle bulging, but this is non-natural. The patients who have no MAD and mitral valve prolapse have a very reasonable thickness of the posterior wall. And this is similar to what happens when you have a rupture of bicipital tendon. You see the biceps very big, and you think, oh, it must be very strong. No, it's just detached from its attachment, so it makes a ball of muscle, and that's exactly the same. The muscle of the posterolateral wall is bulging because it is detached from its attachment to the annulus. Don't overestimate the myocardial function because it bulges. It doesn't mean a thing here, in this case, in terms of myocardial function. And generally, this is all details of, okay, you have MAD in red, you have more dilated annulus, more tissue in leaflet, more mitral valve prolapse volume, more LV thickness at the base, and the dynamics of the mitral annulus is not the same, and I'm going to show it in that bileaflet, mostly bileaflet mitral valve prolapse with MAD. you see that the annulus in late systole expands. It expands. That's one of the features of Barlow disease, that it expands laterally and inferiorly, and that separates the leaflet, and that may be a mechanism of progression of MR. That's the feature of MAD causing that expansion of the mitral annulus. And if we look at the distribution of MAD, we found MAD in 31% of patients in all mitral valve prolapse. In 70% of those, MAD was associated with MR. And if you do surgery, because you suture to the annulus to the muscle in doing the repair, you repair the MAD without knowing. The surgeons repair the MAD without knowing that they do it. And so it disappears in a little bit more than 80% of cases after mitral repair or replacement, by the way. But a number of cases are left because the ring is placed a little too high on the leaflet and not on the muscle, and then the myocardial abnormality may persist even after surgery. So it's very important that the surgeon pay attention to suturing to the muscle of the limb. So MAD, we have seen, now we understand what it is, but we've seen that Cristina Basso has expressed it almost like it's the angel of death, MAD. So we see MAD, we should be afraid and be ready to do something right away. Is it the angel of death? So MAD occurs in the context of the, often of the arrhythmic mitral valve prolapse phenotype by echo, where you see the redundancy of the tissue, the bileaflet prolapse, a little bit of MR most often, and that movement of the MAD. And so it comes into the phenotypic risk feature of the arrhythmic mitral valve prolapse, that is the negative T waves in the inferior territory, the multifocal polymorphic extrasystole or VT, the detachment that we see here with the MAD, and the fibrosis in the myocardium that you can detect by MRI, sometimes with low EF. And in fact, my friend and former fellow Thierry Le Tourneau, who is in Nantes now, another professor of cardiology in Nantes, and he has published a large series of patients with MRI done with mitral valve prolapse with any degree of MR. And he had LGE in 28% of his patients with mitral valve prolapse, mostly on the posterior wall of the left ventricle. And you can see the echo association and the MRI association. And the fibrosis was associated with the regurgitant volume by echo and the regurgitant volume by MRI. So it is associated to the degree of MR. Strangely, it didn't find an association to mitral annular disjunction, and he knows what this is, so we have to sort of investigate that a little bit more. But it is associated. It comes in the context of more tissue, bileaflet prolapse. So severe myxomatous disease of the mitral valve includes the mitral annular disjunction and often fibrosis, but it couldn't prove that association in that series. But what is interesting is that here is the association of fibrosis with the severity of MR. It's associated with the LV mass. But the most interesting thing is not the end-systolic volume here. It's the association to arrhythmia. They find more arrhythmia when there is fibrosis than when there is no fibrosis. So we don't know exactly how it was done, but this association of fibrosis and arrhythmia is another association that you have to take into account in the risk factor for arrhythmic mitral valve prolapse. And so that's the paper that we published with Benjamin and Sayag on arrhythmic mitral valve prolapse, the factor of arrhythmic mitral valve prolapse, MAD, redundant leaflet, and T-wave inversion in the inferior lead. This is the survival with severe arrhythmia that we define at non-sustained VT of more than 180 beats per minute. And the moderate or mild were not different in terms of survival. There was a little bit more different if you include in the endpoint the arrhythmic intervention. The interventions for arrhythmia, it's more divided. But this is the severe arrhythmia associated with mortality. That's the only thing that is associated with mortality. So arrhythmic MVP is independently associated with MAD, but excess mortality is only in the small subset, 9% of people who have severe arrhythmia, non-sustained VT above 180, and this occurs very progressive over time. So what I don't want you is to go and every single person who has 3 beats is going to have an ICD. That is, slow down. It takes a lot of time to have the excess mortality form, so you have time to observe for severe arrhythmia before acting on this patient. And when you look at the annular disjunction and the implication for outcome, annular disjunction is associated with more arrhythmic events than the people who do not have MAD, mostly under medical management with an attenuation post-op. But you see that it's very progressive, the arrhythmic events. It's not everybody has it within the next 2 weeks. And within the first 10 years of follow-up after the diagnosis of mitral valve prolapse, when there is MAD, there is no excess mortality. We match these people with and without MAD, and there is no excess mortality. So yes, MAD is associated with arrhythmic mitral valve prolapse and is a manifestation of severe myxomatous mitral valve prolapse, but it is not associated with excess mortality within the first 10 years. So we have to calm down everybody. It is not the angel of death. We have to avoid acting in a rash manner. So how do we act? What do we do in those people? So to summarize the sudden death, in patients with significant DMR, notable sudden death rate, and the prevention is early repair. In isolated MVP, sudden death is infrequent, but risk is recognized by the triad of syncope, MAD, and high-risk VT. And that's the sort of action that came from the European Association for Arrhythmia work with the imaging group in saying, okay, how do we do? The first thing is that Holter is not mentioned in the valvular guidelines at all. There is not the word Holter. And what we know now is because we know that there is a rate of sudden death, really we need to monitor this patient. We need to do Holters in people who have mitral valve prolapse. Is it in everybody? I would say it's not costly. I would do it in everybody. And I would consider that in a repeated manner because mitral valve prolapse is a progressive condition. So we want to do it, but if it has progressed in 5 years, maybe repeat in 5 years if we didn't find anybody. And so this is a complex picture, but what you have to retain is that the phenotype that we've talked about of arrhythmic mitral valve prolapse, we use it to increase the frequency and the duration of the monitoring to detect the arrhythmia. So we're going to use on the right the phenotype for monitoring, including MRI for the fibrosis, and we're going to use the arrhythmia for the treatment. We're going to treat only by ICD the people who have severe arrhythmia, so polymorphic VT, fast VT, and there is a lot of work to be done to also determine what are the arrhythmic factors that determine sudden death. So more, maybe criteria are better. We said 180. Is it 180? Is it 170? Is it what? So we have to define better what is a severe arrhythmia that will have us do the ICD, or if there is MR, the surgery, mitral surgery plus ICD. So in summary, what we have to change in our management of MVP is detect the phenotype with the highest propensity for development of ventricular arrhythmia, Does that imply doing an MRI in everybody with mitral valve prolapse? I think I would do at least one, and you guys are very equipped here. I was at the meeting in Europe, and people were saying, oh, no, we have to select. Selection is very complicated for a simple mind like mine. If I say mitral valve prolapse, you need at least one MRI in your life. Well, I think we should do it, and we should do a very good echo to assess for annular disjunction. Detect the arrhythmia by monitoring, if necessary, prolong, ILR, and if necessary, repeat it, and not if necessary, repeat it throughout the life of the patient, and treat the arrhythmia based on their severity and the association to DMR. Well, I think you had enough of me. Thank you so much for your attention.
That was absolutely fantastic. Thank you very much.
Thank you.
Thanks for being here. As a receiver of patients with this problem in MRI, it's important, I think, for those who refer to understand that it's not really binary. Sometimes it is. There's groups, but there are many decisions that we make, yes, no, which are subtle and may not be correct. And so to only use fibrosis as the thing to turn on or off an ICD, of course, is the wrong thing. So thank you so much.
Yeah, no, there is so much to learn. I'm trying to convince Joao to look at mitral prolapse here. And so I think that there is a lot of uncertainty, position, amount, sort of like, okay, what's the percentage in the ventricle? To me, it's a very difficult subject, and the data that we have is very fragmented. You have Christine Oga in Norway, very aggressive on doing MRI, but on a very small number of arrhythmic MVP, and you say, no, I would like to have everybody in this thing to know what's really, and that's the work of Letourneau, but it's only partial. It's only like 400 or 500 patients. We need to have more, and I'm sure that we have a resource here that is absolutely fantastic. But at least we can begin to learn by the practice, because there are a lot of gaps. And by having the imaging on one side, the appropriate imaging and the appropriate monitoring, I'm sure we'll learn a lot. It's not a frequent event, but if it kills people, maybe we should pay attention. Yes.
Can you just, I'm a little confused about how the intersection of the degree of mitral regurgitation interacts in these patients with mitral prolapse.
When there is MR, in and by itself, the volume overload may provoke arrhythmias, and you suppress the arrhythmia independent of the form, whether it's a flail leaflet, nomad, irrespective of the form of the mitral valve prolapse. If you have MR, you overload the ventricle, and it's arrhythmogenic. And people have a higher risk of sudden death and ventricular arrhythmias. So you do this. That's very simple. That was my thought. Very simple. You suppress the volume overload, you decrease the rate of sudden death. Now the rest, it's distributed. I think that in the other arrhythmic mitral valve prolapse, the MR doesn't play a big role. It's that complex phenotype of mitral annular disjunction. Is it by itself arrhythmogenic? You detach the muscle. Will it induce something? Or by causing fibrosis, that it caused that? Or by having a large prolapse that pulls on the pepper muscle? You have all the wildest theory on why do you have that extrasystole that will cause the arrhythmia. But we know the phenotype, so we can work on that. And it's a little independent of how much ammo. There was one of my colleagues who had this condition, and he had mild moderate MR, bileaflet prolapse for a while, nothing, no consequence. And then he presented with presyncope and multiform non-sustained VT, and now moderate MR. So he had a repair for the moderate MR and then ICD. But the MR here is less important. It's more the type of mitral valve prolapse that is important in this case.
Thank you.
Maurice, great presentation and so great to have you with us and giving your wisdom, in so many ways. I wanted to ask you a couple questions here. I really like the way you framed that, the importance to look at the phenotype and also look at the monitoring of their arrhythmia. So a couple things. One is ILRs. You mentioned that. What is the evidence? Do we need to generate the evidence? Zero. But it makes sense to monitor because you cannot just take one snapshot of 2 weeks or 48 hours, right? I mean, these things. The other one is, what do we know about the importance of recurrence MR? Because we know the severity of baseline MR is it amplifies the signal for the arrhythmia, sudden cardiac death. But once you fix the MR, is recurrence of MR and severity of that also a promoter?
It took us a long time to see that it's associated with outcome, residual MR, because we had the surgeon saying, it's a little bit of MR, disregard it. I'm not going to do second run, pump run. And then it takes 10 years to say, it affects the outcome, the reoperation, the mortality. And we don't know if in the mortality there is a big segment of sudden death that is affected by the residual MR. It's a very good question. But in a sense, I think the relationship with the surgeon is to press them to have a perfect repair, attached in the right place with the perfect coaptation and no residual at all. Don't give me there is a little bit, it's unimportant. No, that's not true. It's very important. You're gonna have more recurrence if you leave a little bit, and you're gonna have more mortality. So we sort of try to kill it by suppressing the residual MR. Does it play a role in people who are treated by TER? We're in the best position in the world to show it. You have the highest volume to show if there is a link to sudden death. In fact, it would be very interesting to monitor the rhythm in people who have residual MR, because I think we would find stuff that we have no idea. Yes?
There was one report that said that the mean gradient after repair of mitral valve prolapse is related to mortality when it's, I think, more than 5 or so. Can you quantify the difference between the mortality associated with some mitral stenosis and that with, or is that not known?
It's each paper says, it's my factor that counts. You say, okay. I think it plays a role in we never really work that much on obstruction post-repair because we never were, again, in my previous life, into the restrictive annuloplasty. There are surgeons who applied the restrictive annuloplasty from functional to organic and degenerative MR, where in fact you need a large annulus. So I never had a lot of patients with obstruction, very few when the repair was difficult, calcification of the annulus, people try to do an Alfieri, and then you have a high gradient. What you want to have is a relationship to the surgeon to say, please don't do a restrictive annuloplasty when you have degenerative MR with Barlow's disease, because that's not helpful. And that can provoke a SAM. So I'm sure it's something real. We had a number of patients with obstruction, and they become symptomatic, and they come in heart failure because of the gradient and the pulmonary hypertension, but not on the sense of ventricular disease and arrhythmias, more on it becomes a significant mitral stenosis and you have the untoward effect of the mitral stenosis. So it's I'm sure it plays a role, but I can't say how much. Nobody's interested in arrhythmic mitral prolapse online.
Thank you, Maurice.
Thank you so much.